Welcome to Science Distilled Virtual Edition. Today we are bringing you 4 Nevada experts on the science and clinical practice related to COVID-19. We are very privileged to have this group share their time and expertise with us this evening. Our focus tonight is on the state of the research and medicine 1 year into the pandemic, as seen through a local lens. If you are here in Zoom or watching us live on YouTube, we welcome you to type your questions into the question and answer box at any time. We will start with short talks by our panelists, and then we will take questions through the Q&A from you. There are a lot of us tonight, so we're using the Q&A feature only. Whether this is your first Science Distilled or your 15th event, we're glad you're here. Science Distilled features timely topics by scientists right here in our region, and we love introducing you to the great people behind their great work. Science Distilled is co-hosted by the Terry Lee Wells Discovery Museum and the Desert Research Institute. DRI is the environmental research arm of the Nevada System of Higher Education. And now I'd like to introduce Patrick Turner to tell us a little bit about the Discovery.
Hi, everybody. Thanks for joining us this evening. I'm excited to see all of these people joining us tonight for a really timely topic. Hopefully, most of you have visited the Discovery, but if you haven't, I invite you to do so. We're a 67,000 square foot hands-on science museum in downtown Reno, Nevada. Currently, we are open Wednesdays, Saturdays, and Sundays, and we hope to add more days to that schedule. But the best way to find out what's happening at the Discovery, in addition to the Science Distilled series, is to visit our website at nvdm.org. A couple of programming notes about Science Distilled. We normally host these events at the Patagonia Outlet in downtown Reno, which is a great venue and a really fun place for all of us to gather and learn some new things. We also enjoy support from Imbibe Custom Brews at that event series. And we're missing them greatly, but I hope all of you tonight have found a beer in your fridge and you're enjoying it while you take part in the virtual edition of Science Distilled. So thanks for joining us.
Thanks so much, Patrick. Our hope for tonight is that we can reflect on the monumental effort that healthcare providers, clinicians, and researchers have made in the face of the COVID-19 pandemic. I'd first like to introduce Dr. David AuCoin, who is a full professor and chair of the Department of Microbiology and Immunology at the University of Nevada, Reno School of Medicine. And he is an expert in diagnostics, and that's where he will start us out today. So I'm going to share my screen, and we will get started with David.
Okay, thanks so much for having me. Really like this opportunity to chat with the community about the virus. So yeah, I'm the chair of the Department of Microbiology and Immunology at UNR Med. You may recognize this building here. This is the Center for Molecular Medicine. It's North McCarran, so when you're driving on North McCarran, you may have seen this kind of shiny new building. It's about 10 years old, and my lab is in this building, and then there's a lot of other research labs at the School of Medicine in this building as well. So a lot of really great research that's going on in this building. So next slide, please. So I teach virology or viruses to undergraduates, graduate students, and also medical students. And so, you know, what I would do if I was starting off with a coronavirus talk, if I wanted to summarize the virus, I'd probably throw up a slide like this and start off by saying that, you know, SARS-CoV-2 is the virus and COVID-19 is the disease it causes. So, you know, basically it's like saying HIV is the virus and AIDS is the disease that it causes. Shown here is just a schematic or an illustration, a cartoon of the virus. And and so, you know, some notable features that you may want to pay attention to is the virus genome, and that's shown here in the center of the virus. that kind of squiggly line in the middle here. And then also the spike protein is a very important part of the virus. It binds to human cells. So this is the little part of the virus that actually binds to cells on the respiratory tract and allows for the virus to actually enter a cell. And so, you know, when our immune system, when we make antibodies that bind to the virus, we want those antibodies to bind to this spike protein, so it would prevent the virus from actually entering a cell. It's, you know, that spike protein is like a key, and it's trying to get into your house, which is a cell. And so if you put a little piece of gum on the key, which is an antibody, that virus won't get into the cell, or the key won't work on the lock. Okay, so that's what we really want to do with vaccination and also some therapies as well. And another thing I would probably mention is this little picture on the lower right-hand part of your screen here. This is actually a coronavirus that is a picture of a coronavirus, 3 of them that's actually taken with an electron microscope. And you can see the little kind of spikes that are coming off the circle of the virus. And why do we call it coronavirus? Well, corona is Latin for crown. So those little spikes that come off the virus, it kind of resembles a crown. So whoever named this virus, that's why they named it coronavirus. Okay, so next slide. So a little bit about my laboratory. I have a pretty large lab that basically makes rapid diagnostic tests for infectious diseases, and pretty appropriate in this kind of day of COVID. So over to the left here, we have a home pregnancy test. That's what we develop. We can make these tests in the laboratory. So they allow us to detect the virus or detect antibodies that are floating around potentially in patients that have been infected. Shown in the middle here is just one of the diagnostic tests that we have developed for quite a deadly infectious disease that's common in South Asia and Southeast Asia. It's a rapid test that can diagnose an infection in 10 minutes, as opposed to what normally takes 5 to 7 days. So it's pretty useful in that setting, and currently that test is going through the FDA. So I feel comfortable to talk about any kind of any type of diagnostic tests for COVID-19. That includes molecular tests that detects the genome, as shown here in the schematic in the picture on the right here. It'll detect the viral genome, or maybe we can talk about antigen tests that can actually detect a piece of the virus that's maybe in your upper respiratory tract. When they stick that swab up your nose, that's what they're looking for. Or shown as well as a serological test. And serological just basically means they're looking for antibodies that bind to the virus that are present in a patient's blood. So you now know that a patient's been exposed to COVID-19, for example. Okay, so next slide. And so when the pandemic hit, as a department, we really decided that we really wanted to start research on this virus as soon as possible. So one of the problems was we couldn't get back into the laboratory because everybody was basically in their house and kind of you know, shelter in place type of situation. However, when we started working on COVID-19, they allowed us to go back in the laboratory. And you may remember early on when we were trying to diagnose this infection, there was quite a lack of diagnostic tools and diagnostic products we just basically ran out. So as a department, and with help from TMCC and other departments around UNR, we basically made, shown here in the bottom right, 30,000 what are called viral transport media tubes. So, you know, when someone gets one of those swabs that are shoved up their nose, they pull that swab out, they have to put it into a test tube that contains some media that stabilizes the sample. We ran out, as a state, we ran out of that sample. As a country, we ran out of that sample. So we basically made 30,000 of them. We gave them to the Nevada Public Health Lab, and they distributed them across the state. So that's one thing we did. And now the good thing is there's plenty of supply that is caught up with the demand. Other things we have going on in our department, we're also measuring the amount of antibody that folks who have been infected and people who have been vaccinated. We're actually measuring the level of antibodies in the blood of these people. And also in collaboration with the Nevada State Public Health Lab, we're actually sequencing viral genomes on a daily basis and analyzing those genomes. So we want to know if we have, one of those strange variants, that we're all concerned about, that possibly could be popping up in the community. And so one thing I do want to mention is we have an amazing staff at the Nevada State Public Health Laboratory. It's one of those things that maybe not a lot of people know of in the community, but we have an unbelievable director, Mark Pandori, and he's just really doing a fantastic job for this community and focusing on the sequencing and also diagnosing these infections. We're also creating, in my lab, I'm making diagnostic tests for COVID-19, and we're also testing diagnostic tests as well from companies. So they'll send us some diagnostic tests, and we'll tell them whether or not they work well or don't work well. And along with that, we're doing much more. We just basically wanted to, kind of shift our research focus to COVID-19 for the last year, and I think we've made some nice gains. So with that, I'd like to say thanks, for having me on this panel. And again, happy to talk about diagnostics or anything kind of general virology. Again, my lab, we make diagnostic tests for everything from, hepatitis B virus to Lyme disease to whooping cough, some nasty bacteria, and also even Ebola. Believe it or not, we can actually make a diagnostic test to Ebola, and we don't even have to grow Ebola in the laboratory, which is a great thing. So I'm happy to be here, and I'm happy to take questions in a few moments. Thank you.
Dr. AuCoin, thank you so much for being here, and thank you for the work that you do. We'll now introduce Dr. Joe Jimsky, who's a full professor at the Center for Genomic Medicine at DRI and Chief Scientific Officer at Reno Health. Joe and his team study how your genes impact your health and health outcomes.
Thanks, Megan. Thanks for having us. I'm the principal investigator of the Healthy Nevada Project, which is a large genetics study. And almost a year ago today, we started focusing on COVID-19 as well. Similar story to Dr. AuCoin. We felt it was necessary, and we knew that this was going to be a severe pandemic, that we would start studying the impact of SARS-CoV-2, the virus, on the host. So I focus on the host, Dr. AuCoin focuses on the virus. And so we are the hosts, of course. And over the course of many community lectures, we've received lots of questions, particularly related to how the host responds to certain things. We have two incredible doctors coming up who can talk about the impact of the virus on the human body. I'm happy to answer questions about what we've learned genetically, how host genetics impact COVID-19 severity. A lot of ground has been made thanks to participants in the Healthy Nevada Project. We are also studying from a data perspective, long COVID, which you'll hear about in a few minutes. But I wanted to take a few minutes following on the virologist and just talk briefly about probably one of the most astonishing accomplishments of modern medicine, coming up with multiple vaccines in the course of a year and how they work roughly. So the idea of a vaccine is that you stimulate the host immune system by basically tricking it into thinking that it is under viral attack. And we have a new way of doing that now. This is the so-called mRNA vaccine, M standing for messenger, RNA standing for ribonucleic acid. And these are the Pfizer and Moderna vaccines. This is a lipid encoded piece of RNA that is injected into the body, makes its way into a cell, and then the cell, because it has a little human tag on it, is tricked into translating the mRNA into a piece of the spike protein that Dr. AuCoin talked about that's so important for signaling. And then that spike protein generates an antibody production response. And when you have a subsequent infection, then this memory is triggered and you have neutralizing antibodies that protect the body. So both Pfizer and Moderna vaccines are based on this new technology, the mRNA vaccine. You'll be hearing lots about them in the future, I think. So the third vaccine that was just recently approved by the FDA is the Johnson & Johnson or Janssen viral vaccine. And this is a more traditional vaccine where they take a virus, and they weaken it or attenuate it. This is an adenovirus. And then they put in the virus the ability for the virus, once it enters the host, to have the host create the spike protein, again, a portion of it, and then a similar response occurs. This is essentially how all vaccines work in some form or another. Next slide. The important thing to remember about these vaccines, besides that they were miraculously essentially built in the lab and then went through phase 1, 2, and 3 trials in approximately a year, is how good they are. And so don't ignore almost everything except the right-hand column of this slide: protection from death or hospitalization. All of the vaccines, Novavax is a new vaccine that should be approved in May, according to data. The Sputnik vaccine was made in Russia. But all of these vaccines are protecting the individuals in the trials 100% from death or severe hospitalization, I would say. And that's really remarkable. It speaks to the quality of the vaccine, but also the efficacy and safety. There are obviously a few minor reactions to these vaccines, but in general, they are extremely safe and effective. And so with that, I want to leave lots of time for questions. I'm happy to talk about host genetics. I'm happy to talk about our experiences with vaccine. We've been surveying on vaccines for about 2 months now, and answer any other general questions about the research that's happening on COVID-19 in Nevada. So thank you.
Thank you so much, Dr. Jimsky. We have just heard from 2 researchers. Now we are going to turn to our practicing medical doctors. Our first is Dr. Rudy Teja. He's the medical director of infection prevention, and he's a specialist in critical care and infectious disease at Reno Health. His expertise is in therapeutics, or how we treat diseases like COVID-19. Rudy?
Hello, everyone. My name is Dr. Teja. I am the Medical Director of Infection Prevention at Reno Health. I'm also specialized in both critical care and infectious disease. So my agenda today is going to talk briefly about the COVID-19 therapeutics. Next slide, please. Before I do that, I think it's important for us to understand the spectrum of COVID-19 disease. This is a diagram that depicts how the disease evolved over time. Now, we all know in the past year or so, we have learned that the disease, majority of people who have the disease have mild symptoms, and they are mild enough that they actually do not need to go to the hospital. However, there are smaller population who develop more severe symptoms. They ended up going to the hospital and being hospitalized. Many of them going home as well. However, there's a smaller subset of population that's actually develop even worsening of symptoms, and they going into the intensive care unit. So if you see this diagram here, there's a stage 1, 2, and 3. The stage 1, which is the early infection, that represent the mild symptoms. So this is where when you get exposed, you have some, fever, mild symptoms, and you just stay at home and isolate, you are essentially a viral risk phase. And the pulmonary phase is when you started to get more short of breath and require more oxygen. The stage 3, the hyperinflammatory phase, that's essentially when your host started to respond to this foreigners, the viruses, out of control. So the virus, the inflammatory response is very high in the host, and then resulting even more severe disease. You will see in a minute how this knowledge is very important in understanding how we target the disease process by using the medication that targets specific area. Next slide. There are tons of studies out there, and it's actually incredible in the past year since the pandemic started, how people are actively looking and studying of the best treatment, the treatment that works, and what do we do with this disease. Now, if you can see, this is a list of quite a bit of names, and by no means this is inclusive. There's still more potential therapies out there that are being studied, but these are the main ones. The red boxes are essentially what we found that they don't work. So the Infectious Disease Society guideline, which is the IDSA, do not recommend them. And the yellow box means suggest not use. So they have some evidence, but not very good. And then the lighter green is you suggest to use it, and then the darker green is you recommend it. I'm going to focus on some of the drugs that works, and also the ones that don't work as much. Next slide, please. So what works so far? So as you can see, there's not many green boxes there. What we've known, what we've learned since March of last year, steroids is one drug that has proven its efficacy to treat mainly severe disease. And I put that diagram again. If you can see here, the stage 3, this is where the hyperinflammation phase. This is where the steroids works in stage 3, because this is where all the inflammation is happening. So it makes sense, right? So the study's shown only those people who are severely ill will respond to steroids. People who do not have severe symptoms, they don't respond as much. Remdesivir is an antiviral. It inhibits the viral replication. So guess what? Because it inhibits viral application, so it works best during stage 1, because that's where you have a lot of viruses. What about monoclonal antibodies? So monoclonal antibodies are still, I think we need more studies to understand these drugs better, because the antibodies is essentially, we're trying to create, to mimic the antibodies against this virus. And they can work, they're supposed to work early in the game, because when your virus start coming into the body, the human body, you want to attack those viruses right away before they enter the cells, right? Like just what Dr. AuCoin mentioned. So they're supposed to work early in the game. There's also another category called immunomodulatory therapy, and it's essentially modulating or modifying the inflammation. So they kind of work in the pulmonary phase 2 to perhaps a little bit in the hyperinflammation phase. Next slide, please. So briefly about monoclonal antibodies. As I mentioned, there are antibodies and they're supposed to neutralize those viruses. So we call that passive immunity. They target specifically the spike S protein, which is, as you can see there in the picture, it's this red spike proteins there. And there's these two drugs called bamlanivimab and casirivimab plus imdevimab. And as I mentioned earlier, they're most likely efficacious in day 1 to 10 from symptom onset. Next slide, please. Convalescent plasma. The idea is the same as antibodies because this plasma is a collection of antibodies from patients who previously had COVID and they recovered. So they have developed the innate antibodies, and those antibodies are donated and collected and then given to the patients with active infection. The data are not slam dunk data, so currently the stand on this is probably efficacious in early stage and with patients who are high risk of progression to severe disease. Next slide. And then what doesn't work? There are a lot of them, and these are just a handful of names. So hydroxychloroquine, which had a pretty good name in the media in the beginning of the pandemic, it turns out it didn't really work. Lopinavir, ritonavir didn't really work. Ivermectin, which is the anti-parasite medication, that also did not show any improvement of the disease. Vitamins C and D, we don't really know what the role of the vitamin. Same for zinc. Next slide. So that's all I have, and I'm happy to answer any questions later on. Thank you.
Dr. Teja, thank you so much. That was extremely informative. We appreciate it. Our fourth and final speaker is another practicing medical doctor. Her name is Dr. Farah Madhana Lovely, and she is a pulmonologist and intensivist at Reno Health. She's currently chairing the Reno COVID Evidence-Based Medicine Group. Farah?
Hello, everybody. Thank you for having me. I'm going to talk about COVID, long hauler, and long COVID. As a pulmonologist and intensivist, and during the pandemic, taking care of active COVID infections, but what we're seeing all around the world is what's happening after people are recovering from COVID. So I'd like to discuss this, and this is still ongoing understanding worldwide. Next slide, please. So we know the numbers because we hear it in the media, we see it everywhere, but there's millions of people who've been infected with COVID. And there's multiple articles coming out now to say what the world is seeing from people recovering from COVID. And we don't have a final definition because the people who had COVID and who were in the ICU, they are mimicking patients who have had severe illness that were non-COVID that required ICU care. So we call it post-intensive care syndrome. Other definitions, as I mentioned, is either long COVID or long hauler or post-COVID. But as you see the articles on the side, which the National Institute of Health just presented a couple of weeks ago, they're just ongoing as we learn more about what these symptoms are and what do we need to help people recover from COVID. Next slide, please. What we're finding is 33 of the patients who have been infected have persistent symptoms. And the picture depicts what is non-lung associated symptoms. We know that COVID affects the lungs, But these are the symptoms people are presenting for weeks to months that people are suffering with, which is the skin problems like rashes, joint pains, the fatigue, losing hair, and brain fog, which you've all heard about as well. People who are very high functioning struggle to focus now. Next slide. I'm going to go over some studies that were done just to show you that it's worldwide, we're all seeing the same thing. So University of Oxford did a systemic review in 14 countries, and the large circles show the predominance of the symptoms of patients having symptoms 2 weeks after their COVID infection to a few months, less than 6 months, as the studies are still ongoing. You can see brain fog was large, the large circle on the left. Joint pains, fatigue was also predominant. Anxiety, post-traumatic stress syndrome, and sleeping disturbances were noted. Next slide. The Japan experience, again, on the left is saying alopecia is hair loss. 24% reported hair loss. That's a lot of people, and not everybody got their hair back, which is a little concerning. Why is this happening? Cough, shortness of breath, which is what is expected. And that was seen in the graph on the right. Next slide, please. The Wuhan experience, where where the pandemic first started, this is the longest study we have, which is 6 months out. Most patients, 6 months, at least had one symptom, and that's the sleep difficulty, muscle weakness, fatigue, anxiety, or depression. And these are symptoms that people didn't have before. Next slide, please. And then in our nation, Mount Sinai in New York City has the most patients. So far, we're waiting for publications. They've seen over 1,600 patients post-COVID and evaluating their symptoms and seeing how to help our patients with these symptoms. A Michigan study looked at post-discharge. 58% who was discharged from the hospital had problems completing their activities of daily life, which is grocery shopping, taking a shower, getting yourself dressed. That's a lot of people having struggles who didn't have struggles before. People who were employed prior to COVID, 60% were able to go back to work, of which 25% of that 60% couldn't work full time. They had to have truncated hours because they couldn't focus. The fatigue was overwhelming. And 48% of the patients were emotionally affected by the health, whether it be depression or post-traumatic stress. Johns Hopkins published a study looking at ICU versus non-ICU, and the anxiety and depression was prevalent, whether you were in the ICU or not in the ICU, and your functioning status was also prevalent. It was diminished. Next slide, please. So management recommended by the World Health Organization, as well as the National Institute of Health, is for long COVID or post-COVID is you have to take the patient as a whole and look at their functional status, their emotional status, and then the symptoms and address it all together. And it's going to need a multidisciplinary team. And that's what we're all building now, is we are having clinics that we're building to take care of our patients, to take care of the lung problem that the COVID has caused, whether it's scarring of the lung, the oxygen problem, the heart problem, and also take care of the mental health and bring people back to functioning to a level where they were functioning before. Next slide, please. So these are the stand-up clinics around the world and nation where we're addressing this. So far there are about 25 clinics that have been stood up in the nation, and many more, I'm sure, are standing up every day. We do have one here in Northern Nevada at Reno that we stood up within the last month, and we're also collaborating with University of Nevada, Reno outpatient to stand up a clinic there. We're addressing oxygen needs, assessing their lung function, figuring out what kind of rehabilitation do they need to go back to the way they were functioning prior, assessing their emotional status, as well as and using our other subspecialties to help address these post-COVID symptoms. Next slide. As I said, we don't know everything. We're learning. The whole world is working together to learn. we don't know what truly the long-term effects are and how long are they going to last. 6 months after, we're still seeing people with symptoms, as was shown in the Wuhan study. Is COVID a predisposition for heart failure? Studies in Germany looked at MRIs of the heart for people who were infected with COVID. They saw that it did light up. So the question is this a predisposition for heart failure? Is it a predisposition for dementia, Parkinson's, kidney injury, clots? We just don't know. So at this time, we continue to support our community. We continue to work together to help everybody. So prevention remains the best approach to eliminate COVID-19, of course. Please get vaccinated. Thank you for having me and open to questions.
Thank you so much, Farah. I'm so glad that there are many groups that are working so conscientiously to address long COVID. We're going to take question and answer now. As a reminder, you can just open the little box at the bottom of your screen that says Q&A and type in questions at any point. We've got a question for Dr. AuCoin from Edith. Edith wants to know, can anyone test for antibodies? How does that work?
That's a great question. So let's start off with the antibody. So when we're testing for antibody, what are we actually doing? If you've been exposed to coronavirus, your body is going to make antibodies. So, rapid tests can be used to detect that antibody. Why else would you want to know? Maybe after you've been vaccinated and you want to know, has my immune system made antibodies that would potentially protect me from severe infection? That's another good reason to get an antibody test. What an antibody test won't do is tell you if you have an active infection or you're sick now with coronavirus. So what it does is it basically says you've been exposed in the past at some point. So it doesn't really tell you that, hey, I was recently infected and now I can potentially infect other people. So it's a good way to say, I've been exposed to the virus, I have antibodies, or my vaccination really worked and that's great. Now, there's a lot of tests for antibodies out there, and this is a good thing. Most of them have been evaluated by the FDA. The FDA basically says they give approval for a lot of these tests, and they're called emergency use authorization. And that's basically the FDA taking a quick look at these assays and saying, hey, they work pretty well. Let's get them out into the public. Okay. So you can get it. You can get this done probably at your doctor's office, down at CVS. I do it in my lab. It's I don't want to say it's not rocket science, but it's fairly easy to do in the laboratory. But so those are to be quite honest, it's not a good diagnostic test to say I have an active infection. You don't want that one. You want the molecular test, the PCR test looking for the viral genome, or you want the other test, the antigen test, which actually detects a piece of the virus, or like I said, detects the genome to say I'm actively infected. So these are the tests that you would use before you jump on a plane or to go to another country or something like that. Those are the tests that people or public health officials want you to take.
Super. Thank you.
Mm-hmm.
Our next question is for Joe, Dr. Jimsky. Kevin asks, are there dietary or lifestyle factors that would increase antibody production after vaccination?
My practicing medical doctor colleagues can comment on my answer if they don't like it. I would say that what's important post-vaccination is to do what you should be doing all the time, which is eating a balanced diet, getting a lot of rest, exercising, regularly, staying well hydrated, doing everything to support the body in performing its natural function of building up immunity. I'm sure if you play Dr. WebMD, Google, that somebody has come up with a miracle cure that gives you 100x more antibody resistance if you eat, 6 quarts of blueberries. But I think the general rule is to just mind your body and support it, because of course it's undergoing a significant change, which is why most people will feel fatigue, particularly after the second dose of either Pfizer or Moderna, as their body reacts more quickly to the part of the virus, the spike protein.
Thank you. And while we're talking about vaccines, we have another question. Are there other vaccines on the market, like for polio or chickenpox, that use the same sending instructions as Pfizer and Moderna, or is this a very new technology?
That's a great question. So I mentioned earlier the miracle, the moon landing that has occurred. The first mRNA vaccine that was approved for human use was approved on December 2nd, 2020. So think about that. And it was approved by the Brits for SARS-CoV-2. So prior to that, there were attempts to use mRNA vaccines on some other diseases, Zika, among others. They tried them for a cardiovascular disease as well. But this technology was born out of research that began in the late 1990s and 2000s. And one of the hurdles that had to be overcome was how to build the mRNA such that the body didn't destroy it immediately upon entrance to the human body. And that took some massive breakthroughs. I'm sure a few Nobel Prizes were or are being awarded. But the first mRNA vaccine was approved because of the COVID-19 pandemic. I suspect in the future we will be seeing more, though.
Perfect. Thank you so much. So this is a question that many of you might be able to answer. This is from James. What is the current thinking about efficacy of vaccines now that there are multiple variants popping up? Feel free to just unmute yourself and come on.
There have been some natural experiments occurring around the world as the variants have been mutating or evolving, depending on your perspective. And some in vitro studies ongoing by Moderna, by Pfizer on vaccine efficacy. And the way that I explain this to, for example, my mom, who is not a scientist, is thusly. The vaccines produce a generalized immune response that's targeted to the spike protein as it was created by Moderna and Pfizer for the original variant. And it produces a very strong immune response. When the body is challenged with a variant, let's say P351 out of South Africa, it may take 5 members of the army, 5 pieces of gum, to use Dr. AuCoin's awesome analogy, to block the key from getting in the door. But because the immune response is so strong, there are plenty of pieces of gum lying around to attack those particular variants that have been challenged. Now, it is entirely possible that new variants are emerging. There's a new one out of Brazil. I think it's called P1 that is showing some concerning trends. This is why, as Farah has said, we need to all be vaccinated as quickly as possible, and we need to really snuff out this virus. Both Pfizer and Moderna are actively working on boosters for some of these variants, and I suspect that that people will be required to take them because it's going to take approximately 7 years to vaccinate the entire world at the current pace. So the COVID-19, SARS-CoV-2 is going to be with us for a long time.
Thank you. That really clarified things. You want to add? Yeah, David.
Yeah, and Joe's absolutely right. I think, those vaccines are making so much antibody that they are pretty much doing a good job against some of these variants. But antibodies are one arm of the immune system. So they're made by B cells. I love B cells, by the way. I grow them in my lab. But the other arm of the immune system are T cells, right? And this is a little bit harder to study in the laboratory. And so what a T cell can do is recognize an infected cell. And so we also have that whole other arm of the immune system that it's a little bit hard right now to tell how well that's working against the variants. So what we're hoping is the B cells and the T cells together are doing, it's like a 1-2 punch against a virus trying to enter a cell. And if it has entered the cell, then the T cells can come by because they've been trained by the vaccine as well to find infected cells. So fingers crossed, the T cells are helping just as much as those B cells, and we have good coverage against some of these variants.
Making me want to go back to school. That's really helpful. We now have a question from Andrew, and I'm gonna ask both of our clinical practitioners this question. So Dr. Teja and Dr. Adhani Lovely, regarding COVID, what keeps you up at night?
I can start. What keeps me up at night? Oh gosh, back in March to, I don't know, summer or even like November and December, I think the uncertainty that really keeps me up at night, because there's so much we don't know about this virus, and we don't know how to treat it, we don't know how it spreads, and we started to do the best guess we could at the time to help us decide what would be the best intervention, what can we do to our patients. So to me, that's really the most concerning area that kept me at night.
Thank you.
Yeah, I have to agree with Rudy. As a lung specialist, I know how to manage chronic obstructive lung disease, scarring of the lungs, and we've dealt with viruses multiple times and people recovering from viruses. What keeps me up at night is this virus, of how it's affected the lungs and getting oxygen to the patients, and understanding that it's not following the same destruction as the other viruses have done, and trying to figure out how to get oxygen to people and have people breathe without feeling that drowning sensation. And we haven't figured it out, and that is very concerning, and yes, keeps me up at night.
And then the evidence was not there, and you just don't know. I mean, we were trained, so coming up from the training, we always train to do any evidence-based medicine, and then this is a completely new virus that we don't even know what to do with.
It's amazing to me how quickly the science has advanced in the past year, and continue to have a lot of questions that remain. So thank you. We have another question about variants now. This is from Sean. David, this is a question for you, but feel free, if there are folks who want to chime in on this, feel free to pipe in. Sean asks, how many SARS-CoV-2 strains are there, And how many of those have been present in northern Nevada? And I'm going to add an addendum to his question as well. What is your advice for communities in Nevada related to staying ahead of those variants?
Okay, and this is a great question. So to get back to our general virus kind of biology, this virus does make mistakes. So when it's copying its genome, it makes small changes to its genome. So it's like you read a sentence of a book, okay? You know, someone's gone in and changed a few letters, okay? So mistakes are made. And sometimes those mistakes result in a virus that's more infectious or more pathogenic. Sometimes it results in a virus that is incapable of infecting a cell and causing disease. It's the ones that cause severe disease or increased pathogenesis that we worry about. So you know, when we identify these different variants, we sequence them and figure out how different they are from the last one we sequenced. And there's folks in my department that know a heck of a lot more about this than I do. But basically, you start putting all these coronavirus variants into little groups, okay, based on their genome sequence, okay? You know, how similar are those sentences, basically, of each of those viruses? And I believe there's right now there's 5 main groups of variants in the whole world. Now, there's a lot of mutations in these viruses, though. The ones we're focusing on are the mutations mostly in the spike protein, because they allow that virus maybe to enter the cell a little bit more efficiently. And that's when we hear, okay, this variant is spreading a little bit more efficiently because it binds to a cell a little bit tighter and it's able to enter a cell. Now, we have experienced I think we have a fairly normal spread of variants in northern Nevada. Now the folks at the State Health Lab could probably talk a little bit more about this in detail. There have been different kind of variants of concern. For example, I know the State Health Lab has found the South African variant. They sequence, I think, something like 30 isolates a day from patients. So basically, 30 patient samples come in, they have the ability to sequence 30. And that's why I'm saying our Nevada State Public Health Lab really is on top of this. And I think more so than a lot of state health labs. So we're lucky. So yes, I think we probably have a fair range of variants in our community. So far, we have that one from South Africa that was of concern. I'm not sure how fast that's spreading through the community at this point. Maybe Dr. Jimsky knows about that or others. But again, these viruses change, not as quickly as the flu, for example. So hopefully we don't need, constant updates to vaccines, but we may need to tweak it a little bit. Because remember, if this virus changes a lot, it may not be as infectious anymore. So it can only change so much, and hopefully our vaccines will cover, most of these variants. But we worry about the variants because if they do change a lot and evade the vaccine, then they spread easier, right? So hope that answered the question.
Thank you. So, speaking of vaccines, Stephanie asks, how long are the vaccines effective for? Do we know this yet? She says, if I take the vaccine in March, will I be protected for flu season at the end of the year? So maybe we want to compare and contrast flu viruses and corona, SARS-CoV-2.
And I can talk about that if we need to. So, the reason we get a yearly flu vaccination is because the flu has a couple of ways that it can mutate. All right. Like I said, the coronavirus has about 10 genes. The influenza virus has 10 genes. The thing with influenza is the genes are like 8 separate cards in a deck, okay? And when 2 influenza viruses infect the same cell, they can exchange their genes. So a lot of variation can pop up when you just are switching these playing cards around. Now, the other way it mutates as well is when it's replicating, the virus is replicating itself, it makes a lot of mistakes too. So we have to get a yearly update for the flu because it changes so much, okay? Now for coronavirus, it only has that one way of changing where, you know, like I said, the sentence changes a little bit, but it doesn't have that deck of cards where it's exchanging genes all the time and making big changes. So that's a good thing. And so I think when we talk about how long does the vaccine last for, that's a great question. People get concerned about, okay, I was just vaccinated. Now I have all these antibodies in my system, okay? And how long will they last for? And yeah, you get this big spike in antibodies and you feel great, but then maybe in a year, what happens is the antibody levels go down, and that's completely normal, right? Because what happens is we have those tiny B cells that are making the antibodies. And when they see the virus, those B cells replicate and they make a lot of antibody. And when the virus is gone or the vaccine is gone, those B cells calm down, they don't replicate as much. And then there's a few B cells left behind that are called memory B cells. Okay, and so those memory B cells are ready. Okay, so if you're reinfected, those memory B cells will start replicating again, trillions of them, okay? And they will start making more antibodies. So your antibodies can go up and they can go down. And if you're reinfected again, they can go up again, okay? So personally, I think a vaccine like this would last a fair amount of time. I mean, it's years. 5 years, 10 years, because your immune system has memory and it will bounce back. I hope that answered that question.
Very much so. Thank you. You also clarified that coronavirus and influenza virus are 2 distinct things. And so the vaccine that works on coronavirus doesn't work on the flu virus, the influenza virus. Is that correct?
Yeah, because when we're talking about 2 different viruses, basically the immune system recognizes the fingerprint of this virus and the fingerprint of another virus. They're both very different. And so the immune system is quite amazing that it basically recognizes everything you put in your body that is non-self. Okay, so it recognizes all the cells in your body as good, and I'm not going to attack the cells in my body in most cases, and unless people have certain disorders. But once something foreign comes into the body, the immune system is really alert and ready to go.
Awesome, thank you. So now we have a question for Farah and Rudy. Can you explain the side effects that the vaccine causes and why some people experience them and others do not, or some people experience them more intensely than others?
I can answer that question. The side effects that people experience after the vaccines, there are mainly kind of like a flu-like symptoms. And I don't think we have a good answer as to why certain people have minimal side effects and certain people have really bad side effects. But what we have observed so far is that people who previously had the infection, somehow they develop more robust side effects. And that potentially could be due to the memory cells of the immune system, that kind of like alluding to what Dr. AuCoin was saying, the immune system recognizes some of the elements of the virus and they ready to go, so once things are ready to go and battle, and you can start to have all those symptoms. The difference in individuals who do not have side effects versus who have side effects, they don't necessarily translate into, oh, does that mean that I don't have the immunity that I need if I don't have the symptoms? Because I don't think we can make that conclusion. I hope that answered the question.
Yes, that's great. All right. So, question from Linda. She heard on a podcast. Podcast is called This Week in Virology. Michael Mina talked about an inexpensive rapid test that could be done at home for around $1. Have you heard about this? Is this in the running to be commercialized, to be available?
Yeah, that's a great question. I heard the same podcast. It was intriguing. And, I listened to it because that's exactly what I do in my laboratory. I make these rapid tests that can, in 15 minutes, tell you whether or not you're infected or not. And so there's a lot of these tests out there now. I'm not quite sure if the one that Michael Mina was talking about is actually approved, like EUA, emergency use authorized by the FDA. It may be, but believe me, there are other rapid antigen tests that will detect the virus, a piece of the virus that are out there. So yes, they're out there, and yes, these things are super cheap. They cost $1. I mean, in my lab, I can make one for 50 cents each, right? And these are great because they're inexpensive. They don't need to be put in a refrigerator. 15 minutes, you have a result. Now, the one thing with those tests, I won't say they're not as accurate, but they don't have the ability to detect incredibly small amounts of the virus, okay? Because they're just detecting pieces of the virus. But if they're negative, most likely someone is probably not transmitting virus, because when they start becoming positive, that means you have, say, a lot of virus in your throat or a lot of virus up your nose. Now, the molecular test is different because it takes the genome, and it actually, when you take a patient's sample, you take that sample, and the machine called a PCR machine actually amplifies the genome of the virus. So now this test becomes very accurate, right? So when that's negative, you pretty much know you don't have any virus in your throat or in your nose, and you pretty much know you probably do not have an active infection.
That's really helpful to clarify. Thank you. So I have one more question, and I would love for each of you to chime in, to give a perspective on this, because this is really big and kind of wide reaching within the context of this pandemic. We've heard a lot about the social determinants of health in the last year. So social determinants of health being the factors in your life that make you more or less resilient to illness, including, our zip code and other vulnerabilities that have nothing to do with our physiology. This explains why some vulnerable communities are hit harder by the virus. Can you talk about the social determinants of health patterns here in Nevada and what can be done to make resilience to the pandemic more equitable, or health in general?
You want to start, Joe?
No, you be my guest, Rudy.
Well, one of the first things that came to my mind in terms of social determinants that I've observed in this community is, I think there are certain areas in the community where people gather more, whether that's culturally or for religious reason or whatever it might be, they tend to gather more, and that kind of defeats the purpose of trying to social distancing. And I know it's difficult. It's not something that we all used to, and that could potentially increase the spread of the virus.
Thank you. Joe, then Farah.
I think that's, probably $1 trillion question that you asked, Megan. We've seen, particularly in the United States, tremendous health disparities in terms of COVID-19 outcomes. And I think that these are, massive problems. The former CEO of the progressive and large health system in Pennsylvania called Geisinger said, if you tell me your zip code and your genetic code, I can tell you when you're going to die. And there's some truth to that. And I think, hopefully one of the positives that's going to come out of this pandemic is a change in how we understand and respond to public health problems, because it's not an individual problem when you're dealing with, a massively infectious disease, right? It is a public health problem. And we don't have a public health system of care in the United States. We have individual health systems that act to make as much money as possible, probably, the nonprofit ones accepting. And I think, we need to have a reckoning with these crises. And this crisis, you could ask the same question if we were talking about increases in diabetes, lifestyle disease, metabolic disease in the United States that we're, opioid, you name it. And I think we need a bigger focus on public health issues that arise when we have pandemics or other, other epidemics.
Thank you. Farah, then David.
Actually, Joe summarized it really well, because even though we separate the physiological aspects from the social determinants, they're correlated. So the problem with diabetes and hypertension and obesity, these are the high risks for COVID infection as well, including the gatherings, of course. And you've got to address one to address the rest. So Joe summarized it quite well. So.
Yeah, and just to add to that, this is a great topic, and health disparities are huge. So this issue has to be everybody's issue, because if we think about it globally, if only the developed countries are receiving these vaccines, what will happen around the world? The folks who can't afford it, or the folks who don't have a universal health care plan, or they have no health care plan at all, they're going to get delayed in the vaccination. And all those people are more susceptible to infection and more susceptible to this virus mutating and creating variants that could circle back and infect all the folks in the developed countries. So that problem needs to be our problem. Everybody needs to be vaccinated free of charge, and as fast as possible. And that's it's a massive problem, and it's all coming to light, I think, with COVID. And we're seeing health disparities. We're seeing disparities with education. So many issues, and hopefully from all this destruction and death, unfortunately, hopefully we figure out some better answers to these problems.
Thank you. Thank you for your thoughtful answers. Thank you for your very well prepared talks. We appreciate it. Thanks to our audience for joining today. We had so many questions, far more than we could answer tonight. We will look for a way that we can actually answer your questions on social media. So keep an eye out on the Discovery and DRI's Facebook and Instagram pages, where we'll share the recording as well as some of the answers to this. So we really appreciate it. We're going to close tonight with a little plug for what is going on at the Discovery. Patrick, do you want to share any upcoming plugs?
Sure. Thanks, Megan. Right now, we have actually a display that was created by the New York Museum of Science that talks about viruses and particular COVID-19. So if you're question wasn't answered tonight, maybe a visit to the Discovery will help you find that answer. But in addition, we have all of our other usual exhibitions that we hope you'll come and explore. I think I mentioned we're currently open Wednesdays, Saturdays, and Sundays, and advanced tickets are required. So
Great. Advanced tickets and masks, I'm sure.
masks, yes, social distancing, everything we've talked about this evening.
Yep, very good. Thank you, Patrick. And finally, I will just say, please join us for our April Science Distilled event. We're celebrating Earth Month. The theme of next month's event is protecting the Earth. So save the date for that. It'll be Wednesday, the 28th of April. Until then, be well.